Hello, and welcome to Women's Health. Today we're talking to Dr. Ellen Miller, who is joining us to talk about sleep apnea. This is Women's Health, which is provided to you by the Mayor's Commission on Women and the Women's Foundation. And in our programs, we try to talk about things that are important to women and women's health, but that really work for everyone. And today, we really feel like the topic that we're talking about is current and it's important for everyone to know about, not just women, but men as well. And that is sleep apnea. Dr. Ellen Miller is a pulmonologist, and she is here to talk to us about this important topic. So welcome.
Thank you.
And thank you so much for being here. First of all, I'm not sure that all of our audience will even know what sleep apnea is. And so if you could just start us out with a basic definition, that would be great.
Sleep apnea, or as it may be easier to think about it as sleep disorder breathing, is issues with breathing cessation during sleep. In other words, periodically during sleep, the patient's airway may either become totally or partially obstructed and affect their oxygen level while they're sleeping and lead to other physiologic issues, including daytime sleepiness because they have inadequate sleep at night and disrupting a normal sleep pattern.
So this would be something that people do not realize they are doing.
Very many may not, yes.
Okay. So then I guess the question is, if sleep apnea is happening to you, how do you know that it's happening? I mean, what would be the symptoms that you would need to look for?
Most people would notice that they are just fatigued all the time. They're tired when they go to bed. They feel like they slept 6 to 8 hours. They wake up in the morning, they're still tired. They may have a headache when they wake up in the morning. They may feel that they are having more trouble concentrating at work. They will find that they may be falling asleep even while driving their car, which can be catastrophic. But even just in a meeting, they may doze off. If they're sitting at their computer, working at their computer, they may doze off. They're at home watching TV or reading the newspaper or reading a book, they may doze off. Sleep partners may notice that they're snoring. They may also notice that individuals actually seem to stop breathing at night. They may actually see the apneas. The sleep partners may also notice that patients may be very restless when they have the episodes where they their airway may be obstructed. They may have some jerking.
Okay, while they're sleeping.
Okay. The individual themselves may notice that they wake up feeling like they're choking in the middle of the night, or waking up feeling like they can't breathe.
Sure. Okay, that makes sense. So if someone has some of these symptoms and they go to the doctor, okay, and they probably would maybe go to their general physician or something like that, and they have these symptoms, then what is the key that gets them to actually get a diagnosis of apnea?
To actually make the diagnosis, patients are going to need, individuals are going to need to get a sleep study of some kind.
A sleep study, okay. And would you explain what a sleep study is?
A sleep study is a test that is done as an outpatient, although you will either come to the hospital to sleep overnight or do the test at home. With a in-hospital sleep study, the patients have EEG wires attached so you can tell what stage of sleep they're in. They have monitors that monitor the heart rate, plethysmography that monitors the chest and abdominal wall movements, air thermistors that will measure airflow through the nose and the mouth.
Okay.
Oxygen monitor, which is generally just an oximeter on the finger. Also be some electrodes near the eyes so you can tell when they're in REM sleep to measure the eye movements. And there are also electrodes on the arms and legs so you can tell when those limbs are moving.
Okay.
And they are monitored the entire night when they sleep. And when a tech is scoring the test, they score abnormalities for every 30-second period of the night. So as you can imagine, if somebody's sleeping 6 or 8 hours, that's a lot of information.
That is a lot of information
to go through, but it needs to be. That's how intense the in-lab study is. Now, probably in the last year or so, some insurance companies have allowed patients to have a home sleep study. It's much less involved. Patients have an oxygen monitor on, they have airflow monitors on, and then they have monitors to tell when their chest and abdominal walls are moving. And that will give them a rough idea. That will count the apneas or the hypopneas, which is like a partial obstruction of the airway. It will also measure the oxygen level and the heart rate. But those studies can be used to make a diagnosis of sleep apnea in certain cases. And it's helpful sometimes to have that for some patients because sometimes it is a cost issue. It's generally quite a bit less expensive to do a home sleep study than one in the lab. But there are some medical conditions that require the patient be in the hospital to actually have the sleep study done.
Study done. Well, it's interesting because, I think snoring is something that a lot of people hear, know about, joke about.
Right.
Snoring is probably one of the most common things that you hear about. So if you have a partner and the partner is snoring, or if you hear something about snoring, does that necessarily mean that person would always have apnea, or does it mean that, can there be other reasons for snoring?
There certainly can be other reasons for snoring. In patients who have sleep apnea, about 80 to 90% of those individuals will snore. If you're taking a group of snorers, probably 50% or less of those people will have sleep apnea. So yes, it can be a marker, but just because somebody snores does not automatically mean they have sleep apnea. The chances are, maybe 50-50, which is fairly high.
I was going to say that is pretty high though.
But
50-50.
yeah, but not all people who snore necessarily have sleep apnea. There may be other issues, mostly in the upper airway, large tonsils, adenoids, elongated soft palate sometimes can cause people to snore.
But an extreme situation of snoring or jerking or whatever in the night is a pretty good indication that you should talk about that with your physician.
If it's snoring alone, chances are it's probably not sleep apnea, but the snoring along with the other symptoms of the daytime hypersomnolence, difficulty concentrating, sometimes patients will develop high blood pressure or have more difficulty controlling their blood pressure. There are other metabolic issues that can be related to sleep apnea as well.
And to get a diagnosis, is there a varying scale? This is not such a bad apnea, this is more, this is more. What kinds of scores are we talking about here?
When you're diagnosing sleep apnea, what you're looking at is the apnea-hypopnea index. And that is that's basically the number of times the patient either totally stops breathing or their breathing is partially obstructed to the point where their oxygen level will drop at least 4 points, the oxygen saturation. Usually you have to have an impairment, a change in baseline for a hypopnea from 100%, which would be normal breathing, down to about 30%. If it's obstructed down to 30% and the oxygen level drops 4 saturation points, that would be considered a hypopnea. For an apnea, it's total cessation of breathing with the oxygen, with the drop of the oxygen saturation. Mild sleep apnea, anything less than 5, we would not consider significant, probably.
5
apneas, 5 per hour.
5 per hour. So this would mean
stopping
breathing 5 per hour.
On the average of 5 times per hour, either have a stoppage or a partial blockage of your breathing.
And then that's not bad. But then, when you talk about apnea, what's a typical number for people?
For patients who have sleep apnea,
right.
It can be run anywhere from relatively mild to actually quite severe. Mild is 5 to 15 apneas per hour, apnea-hypopneas per hour. Moderate would be 15 to 30. Greater than 30 would be considered severe. And
so 30 times of stopping breathing in an hour. So
and
that's every 2 minutes.
Well, I've had patients that have had apnea indexes that have been over 100. So
100 times in an hour?
It can be. It can be very severe in some cases.
Oh my gosh. So that is really significant.
That is very
If you stop
significant.
breathing that many times, I mean, if you think about it during the day, you absolutely wouldn't even imagine that you could stop breathing that many
Right.
times and still keep going.
Right.
Well, no wonder you're not getting very good sleep.
Right. I mean, and every time you have an apnea or you have an event, what tends to happen is the oxygen level drops fairly quickly if your breathing motion is actually, if your airflow is actually stopped. And the brain is very sensitive to that. It needs an ongoing supply of oxygen to function properly. And as soon as the brain senses that it's not getting enough oxygen, it causes an arousal. It causes the patient to have enough of an arousal that they start breathing again. Usually, almost always, the arousal is not enough to get them back to consciousness, but it will start them breathing again. When that happens many times in an hour, it disrupts the normal sleep pattern, and so the patient never gets a normal night's sleep, and that's why they're fatigued all the time.
So that's why they're tired all of the time.
Right.
Wow, that's amazing. So what are the long-term consequences of not having sleep apnea treated? I mean, people go on for years, I would imagine, not realizing that they have this. So
That's true.
what are the long-term consequences?
It certainly will affect, their general well-being. If you're tired all the time, you don't want to do anything, you feel terrible. However, as far as medical consequences, these patients may have high blood pressure. If they've developed diabetes, and many of them have, because let's face it, the people who get this majority are significantly overweight. Probably 80% of patients who have sleep apnea are significantly overweight. Their diabetes becomes more difficult to control. If they have coronary artery disease, they are going to be more susceptible to having cardiac events during sleep.
So heart attacks or whatever.
A heart attack, or even just an arrhythmia that could be fatal.
Okay.
And patients who already have congestive heart failure are much more likely to have sleep apnea. And if their sleep apnea is not treated, it's much more difficult to keep their heart failure under control. In patients who have sleep apnea that's untreated, the chances of them having a heart attack or stroke during their sleep hours is much higher than it is in the population that doesn't have sleep apnea.
That would be seem to be pretty obvious.
Right.
Okay, let's talk about the difference then between men and women.
Okay.
Because in some of the research that I've done, I think that it sounds like apnea is more often suggested as a something that men should consider, but not as often for women. And so I'm wondering what your take is on that. I mean, this is a women's health program, but I think that from what I'm reading, it's becoming a big issue for women as well.
It is, and I think that most physicians are starting to recognize that. But I think some of the issue is that when women come in and complain of fatigue and not sleeping well, and maybe some mood changes, their doctor is going to think, oh, she must be depressed. If a male comes in with those complaints, then they may be steered more towards sleep apnea. And I think that was true a few years ago. I don't think it's true any longer. I think that most physicians are tuned into the fact that those symptoms are going to be a marker for sleep apnea for both genders. Now, it is true that males have a higher incidence of sleep apnea
They do.
than women. However, that changes at menopause. At menopause, it tends to even out. However, women who are significantly overweight are going to be at higher risk of having sleep apnea as men that are at that weight.
Okay. But it doesn't have to be necessarily someone who's overweight, because
No, it does
women
not.
Postmenopausal, it would not necessarily be overweight.
I think the stereotypically patients who have sleep apnea are thought of as being significantly overweight, but that is not true. I know that in my practice, but I will say that the majority of them aren't. The majority of them are overweight.
Okay.
However, certainly we all in my practice have patients that are quote unquote normal size, whatever you think that is.
Right.
And do have sleep apnea. Sometimes it's related to genetics, from the standpoint of there may be some structural differences in the construction of the jaw or the tongue or the face that lead them to be more likely to have an airway obstruction when they sleep. And that is something that may be a genetic.
So that would be more anatomical.
It'd be an anatomical issue, but it may be something that's likely to happen in that family because of their genetics.
Oh, that makes sense, yeah. Well, then let's talk about children, because now I think there's more coming to light about children having this same issue. And so how would is snoring again the thing we would look for with children, or?
Well, I'm not a pediatrician, so I will preface whatever I say with that. But I do think that the issues with children are similar to the issues with the American population in general. Kids are just more overweight than they used to be. However, it's a little different in children because my understanding is, and I don't treat children, but children who have sleep apnea may actually tend to be more hyper than fatigued. And the other thing is because at younger ages, children are going to have tonsils that are quite large. And adenoids that are quite large.
Sure.
And in patients who, in young children who may have sleep apnea, that may be a consideration, is removing tonsils and adenoids. It's not a risk-free procedure, but it may correct the problem.
But it could help that.
It could help.
And you know, you were talking about women who have an anatomical issue with their throat or their airway, you know, up in here. That could be true of children, I would guess as well.
I mean, individuals who have a smaller lower jaw or a lower jaw that is receded a little bit may have a smaller maxillary ridge as well. Also, in everybody, the tongue is attached to the lower jaw. So if your lower jaw is a little bit retracted, that leaves less room in your mouth for the tongue. And when you fall asleep, the tongue is the largest structure in the mouth that will obstruct the airway.
Okay, so let's talk about treatment. Let's say someone has a diagnosis. What's the next step?
Once they have the diagnosis, the usual treatment is CPAP, and CPAP is continuous positive airway pressure. And what that device is designed to do is deliver air at a set pressure to stent open the airway or prevent the airway from collapsing. And it's not one size fits all. Generally, we will have patients come back in for a sleep study with CPAP to titrate to figure out what might be the best level. There are caveats to that. There's some patients who may have, for instance, some patients have higher incidence of apnea when they're in REM sleep than non-REM sleep. Patients may have a significant difference based on their body position. Anybody in a supine body position most often is going to have a higher apnea-hypopnea index when they're laying flat on their back than if they're laying on their side. And sometimes that can be helpful. The machine itself is actually a lot smaller than it used to be. I mean, it used to be, the size of, a carry-on suitcase. I mean, really, the original ones were quite large. Now they're, about the size of half the size of your toaster, probably. The interface or the mask that you use, there are masks that fit over the nose and mouth. There are masks that just fit over the nose, and then there's what we call nasal pillows that just fit under the nose, just fit inside the nose. And there are many variations of all of these. And it used to be more difficult. Patients had trouble becoming used to the interface or the mask. Now that we have so many different options that usually we can find something that people can tolerate.
We have one right here.
Yes.
So maybe you can explain a little bit how that one works.
Well, this is a full face mask, and the way this would work is this is the headgear. It would go over the base, and the mask would need to be tight over the face because there's going to be air that's going to be coming through here at a reasonable pressure, and you don't want it leaking out. And once this is in place, you put the loops on to hold it in position, and then there's adjustments here that you can make so that it will fit properly on the face. And then this is attached to the CPAP device that will deliver the pressure at whatever it's set at, depending on what that individual needs.
So more or less depending on what the individual
Depending
needs.
on what is found that they need with the titration study.
And I would imagine that a lot of people would balk a little bit at wearing this, or
That's not anybody's favorite thing to do. I will admit. They are usually patients will at least try, and oftentimes they have such a great improvement in the quality of their sleep that they learn to live with it.
they realize after a period of time
Right.
this is really important.
It is making a big difference in how they feel and how they function during the day. There are other options, and the two that are probably used most is an oral appliance, which is basically a device that most often dentists will construct. But mostly what it does is it pulls the lower jaw forward
Okay.
when you're sleeping, and it may be beneficial. It's not going to work for people who have severe sleep apnea. It's probably only going to work if the sleep apnea is relatively mild.
Okay.
You know, if
That
the
makes
apnea-hypopnea index is probably 5 to 15. When it gets higher than that, it's not as effective, and it's not without issues. Most insurance companies will pay for it if we're clear that this is you're going to the dentist for a procedure, but we're treating a medical problem. However, some insurance companies get a little touchy about that. However, the oral appliance is usually going to run, and I'm not a dentist, so I hope I'm not misquoting, somewhere between $1,500 and $2,500. And once it's been constructed, you need to go back to have adjustments made. And there are some issues that can cause malocclusion, will change your bite.
Okay.
And it may also cause some TMJ issues because, as I said, it's going to pull your lower jaw forward.
Sure.
And it may cause some discomfort here.
Sure. Now, comparatively, what would be the price of a machine, the CPAP machine?
The CPAP machines, I haven't quoted that lately, but they're probably somewhere between $1,500 and $3,000. And insurance companies will pick up the cost of that generally. Most of the individuals who have a CPAP machine will be able to get a new mask, depending on their insurance company, generally every 3 to 6 months, and also all the equipment that goes with it. The oral appliances, generally, once you have one, and that's only going to be effective for patients who have all their own teeth. If somebody who has dentures, an oral appliance is not an option because you can't keep them in.
Right, right. But it does really seem to make sense that the insurance companies are, this is preventative, right? I mean, it's very much important for us to think about what we could do for our general overall health. And if it's improving heart and it's improving brain function and things like that, it would make sense that this would be an important thing for them to do.
Well, this is actually treatment for their sleep apnea.
Well, that's true.
But it does have implications for cardiovascular health and metabolic health in general.
Right, wonderful. Okay, well, thank you so much. This has been very, very interesting.
Okay.
I think it's such an important thing for our viewers to know that apnea is something that isn't just for old guys,
Right.
I mean, there are so many other people who are being affected on a regular basis, and hopefully some of our readers are having the opportunity to think, okay, wait a minute, this could be true for me, and like you said, it might not just be depression or fatigue or whatever,
Right.
that there could be some real serious consequences for this, and definitely something to think about for all of us. Well, we appreciate very much. This is Dr. Ellen Miller, who's been here with us today and talking to us about sleep apnea. We also want to say thank you to our viewers for tuning in, and please be sure that we have some websites on the program here that we would love to have you go to and read more about this topic. But as well, you can access this program or any of the programs that we have done on women's health on our website, which is the Women's Foundation website of Lincoln and Lancaster County. That you can access by going to www.lincolnwomen.org. And if you find the health programs, I think you'll find that there are a lot of different programs, and this has certainly been an important one, and we thank you so much for being here with us, Dr. Ellen Miller. And this is Women's Health.